the Royal we've established a trauma team which consists of the emergency department, surgery, orthopaedics and anaesthetics. So when any patients are coming in, we get a alert from the ambulance service to say we've got somebody with major trauma and we need a trauma team. We put out a call for a trauma team and those people appear here in the department usually before the patient arrives. So as the patient arrives severely injured, we've got all the experts here ready to receive the patient and treat that patient. Prior to being a major trauma centre, patients would arrive by ambulance and then we would decide whether we needed to call down specialised services. The way things work now is we know this patient's coming before it gets here, we know what's wrong with them, or we know what the injury is, so we can call down people. So as the patient arrives in the department, the team's already here, already waiting for that patient. So it expedites their care. The time it takes now to get patients to CT scan or into theatre is greatly reduced because obviously we've got the team here when they arrive, all working, ordering investigations, treating that patient, so the patient's actual care is much better and much quicker. Even in a trauma situation, patients have needs. They need to have their dignity preserved, they need to be reassured. They're often quite frightened, so it's a big part for the nurse in that team to make sure the patient feels safe in our care. It's very rewarding. I've been in the emergency department for a long time. It's something different every day. You meet lots of nice people, you develop relationships with patients, and it's very nice when patients come back and say thank you very much.
There's been a lot of national audit work really around hip fracture, and it was seen that nationally the care wasn't standardised, so there was a lot of different variants of care across the UK. So the important part is really that there are complex elderly patient group who we need to have standardised care practice for. The reason we opened the necrothema unit was really that we could concentrate patient care into one specific area so the patients aren't dotted around on the wards. Length of stay was about 30 days when we first started. We're down to 18 days now and we're below national average. We've done a lot of work with pressure ulcers. I think when we started we were about 7% and we're about 0.8% now at the moment, and we're well below national average there. A lot of our patients develop what's called delirium, which is a post-op acute confusion state. So we did a big project around cognitive care, and part of that was we looked at nutrition. We trained up the hospital volunteers and they come and provide a nutritional support service for the patients.
Well, if you think about the nurses, they're really busy. It's easy for me to sit with the patients and help to feed them, cut up the food or encourage them to eat. It's much easier because I don't have any other role to do. That is my role, and it's great.
The orthopaedic injury is described earlier as the hip fracture is a devastating injury in itself. Because obviously the problems with lack of mobility for patients who might have mobility problems anyway. But these patients also present with a lot of comorbidities, cognitive issues, as we've said. So I think it's great. We've done some great work. We're really proud of it.
The team supports infection prevention and control across the whole organisation. Obviously we have key targets and performance indicators that we need to meet, and our role really is to support the clinical teams in meeting those. We have an excellent reputation for our infection prevention and control. We've met all of our key targets and performance indicators in the last few years. Our healthcare associated infection rates are amongst the best in the country. We have stretch targets for the next 12 months for both C. difficile and MRSA bacteremias, and we're working very hard across the organisation to help meet those targets.
My role is to organise and deliver clinical skills training primarily to our medical students, medical staff and allied nurses and allied health professionals. ANTT is aseptic non-touch technique. We have translated the principles of ANTT to a simple procedure like the administration and the preparation of IV medicines, and it's quite challenging in the sense that we have to change people's mindsets in the way they do basic clinical procedure such as IV medicines preparation and administration.
Training is key to reducing infection across the organisation. Without training and competent staff, we put our patients at risk.
We have to change the culture, we have to change our mindset, we have to change the way we think and we approach things. And that is the fundamental challenge of the conversion from the old way of doing things to the new way of doing things, which is ANTT.
One of the major issues with endoscopic procedures is infection. And if a scope isn't fully decontaminated, you can have serious complications. I basically supply the service with decontaminated scopes for use on patients. We don't only supply the urology centre with scopes, we also provide theatre with a different style of scope. So it's the service can be quite demanding at times. We have very little patient contact. It's mainly to deal with the service, providing the doctors with equipment and, as I say, theatres. This is a brand new suite. These are the state-of-the-art automatic endoscopic reprocessors. Basically, scopes are manually cleaned in this area and then put through the reprocessors, and then they are ready for use on patients. Initially, I was part of a larger decontamination team, and we've now had to move to conform with the current guidelines. My role has developed over, I'd say, about the last 12 months through a process of development and training. Some of the training's been in-house and some of it's been externally at a Lancer Academy in Cambridge. Initially I started in the unit as a Band 2 healthcare, and through the identification of a need for a decontamination lead, I have progressed to a Band 3 and I'm now a technician in decontamination. In the near future I will be joined by a second decontamination technician, and it will be my role to develop their skills and to provide some training in-house for the person. We are providing an essential service to the unit, a decontamination service which is essential to the well-being of the patients.
We have patients who have very complex needs, medical problems, who really can't be managed outside of a hospital setting, patients with learning disabilities, physical and social impairments. So basically our aim is to provide oral care for them.
Most patients would be aware of going to a dental practice outside and having all their treatment delivered there. Here in the hospital we have those subspecialties divided. One of the specialties is involved in treating patients with learning disabilities, and those patients often have great difficulty being treated out in the community. We're able to offer treatment either under sedation or under general anaesthesia. We will try and set up a meeting with the people who care for the patient with a learning disability so that we can try and have a smooth transition from their home to the clinic. I mean, continuing professional development is important to all registered professionals, and in order to maintain your registration you have to demonstrate that.
Last year I managed to get put on a Dale Carnegie management course, and it gave me a lot of experience in teaching me how to communicate in open forums and in meetings, and it also gave me the capacity to empower my own staff through appreciation of what they do every day to help run a more efficient service.
I'm really proud to be associated with the dental hospital. I've been here 5 years now, and the last few years there's been a team nominated for a category for the Trust Awards on each occasion, and we've been fortunate on 4 occasions to win an award. And that's down to the hard work of the individual staff and the teamwork and collaboration that we have.
I feel that we are quite a gold standard, really. I am very proud of this department, and our practices are the best they can be. That's what we're here for. We're here to provide the best care and the best service we can to our patients.
The role of dementia practitioner is brand new to the Trust. I'm not aware that there's that many other practitioners specifically dealing with dementia in other trusts nationally either. Potentially, all our loved ones ourselves are going to experience some form of dementia-related care. And I think if we can start getting things right now, maybe that'll alleviate some of the challenges for the future. The approach I've adopted is utilising an existing communication tool called This Is Me. The This Is Me document is a way of demonstrating that we engage with patients and their relatives individually, and it gives them the opportunity to put forward their opinions and knowledge of that particular patient that we may never elicit during their stay.
The This Is Me document just gives all the staff a knowledge of this patient because the family members aren't always available to help us, so it's just such a useful tool. It's a topic for conversation. We can jog their memory back to things they used to like doing, and that can be really helpful to a patient's care and their progress.
The benefits of identifying a dementia patient in a clinical area may be that the catering staff within the hospital, when they approach a patient that's probably telling them that they've had something to eat already, may not actually have had anything to eat. So by validating that information with other members of the staff or relatives, it means that they're not missing meals and a nutritional risk. 8 months ago at a local conference, other trusts were able to demonstrate that they were doing some things around dementia care. Now they're asking to emulate the blueprint of the role that I'm doing at the moment, and they're saying that they feel that they need to catch up with us now.
Depending on the type of dementia, it is challenging for the staff, the family and the patient. One of the biggest barriers is the communication, so we have to do everything we can to knock them barriers down and make their stay as best it can be for them.
The patient journey used to be, before the Peru unit was opened, this patient would be admitted to anywhere within the hospital surgical bed base, and that could be on any ward really where there was no sort of direct speciality towards pancreas. From there they'd go to theatre, and from that point of view they'd go to POCU, where they'd spend 1 or 2 nights in POCU and then a further 1 or 2 nights in the high dependency unit, and then be transferred down to us either on 5A or 5B, again scattered across the 2 wards. Whereas now opening the unit has enabled us to hopefully take the patients on day 1 from POCU straight to us, completely omitting a HDU stay. We've massively reduced our length of stay by using the pancreatic pathway and using the enhanced recovery programme, which has benefited patients massively from that point of view. I think one of the things that patients really benefit from is having the same staff looking after them day in, day out, and you really get a real continuity of care, and it really pushes things forward from that point of view of really they know the staff and the staff know them, and we know where we can go from, rather than a different member of staff coming in all the time. And I think that that's something that really enhances their stay and really improves their stay.
I have had a pleasant time really, if anything. I mean, when I've been low, I've been low, and even in the middle of the night they'll come and they'll just talk to you and give you that time. They all come in the morning and say hello, and they call you by your own name, which is nice. And they all seem to have this caring attitude, and that's what a patient wants really. This group of people are really exceptional.
One patient actually came back, and the statement was that what the patient needs is a caring nurse who shows that they have a good knowledge of the speciality, a knowledge of what the patient is there for, how long they'll be there for, how they'll be cared for, and ultimately how they will get them home. Which we felt really, from our point of view, that is healthcare really within a nutshell.
So the main body of our work is down here in the A&E departments and the emergency admissions unit, where we're seeing patients with stroke, suspected stroke, at the front door.
If any patients seen by any paramedics, they think it is a stroke, they're always alarming us to giving information that the patient is coming into A&E. As soon as the patient arrives, we assess the patient quickly, and if we think it is a stroke, we obviously contact the on-call consultant, and we do necessary arrangements for further investigations like bloods and ECGs, and arrange for CT scan.
It's vital that our nursing team are the most competent practitioners that are around. There's tremendous responsibility on the nursing team to streamline the whole process and act in the delivery of it. It's not the easiest diagnosis in the world to make, but this team, the experts. I got a call while the other stroke specialist nurse was busy with something else, and we were at the scene down here within seconds and thrombolised this lady in 22 minutes, which at that time for us was something of a record, but Within about 2 minutes of that happening, we thrombolised another gentleman in the space of like 17 minutes. He actually walked out of here 2 days later, and I've just seen him a couple of weeks ago, and he's fantastic. More and more hospitals are getting on board with this kind of treatment. That said, we are at the forefront in this country and Wales of stroke care, and if we look into our stroke sentinel audit figures and also our stroke improvement national audit programme, we're something like third in the country. So I think we're really proud of the fact that we've come from being lagging behind our competitors to the point where we're actually outstripping them now.
This role, I've developed it myself. It's been a new role within the Trust, and I feel quite passionate about continence care. I am here to develop staff on the ward, actually get them introduced in the continence care. Continence has always been seen as the low priority when a patient comes into hospital, and it was found that 70% of hospitals didn't really have a good continence pathway. I was brought in and I was asked to develop a continence pathway, which I did. It was sent as part of our action plan to the Royal College of Physicians, and it was seen as best practice, so I brought it in. When staff have looked at my policy or used the initial continence assessment, they have seen positive results from patients and how quickly they regain their own continence on the wards. If there's any existing problems or problems that need further input, then there's a referral made to me on ICE, and then I will go and assess those patients. By inputting continence care, we can reduce a lot of other problems that occur with the patients. We can reduce the falls, we can reduce pressure ulcers, we can also reduce catheter-associated infections. We're talking of 1 in 20 people having a continence issue in their lifetime. That's a lot of people walking through the door that will have problems. So just by assessing patients, giving them a management plan and giving them some help and referring them on to the appropriate people, we can help them.
One of the projects that we're working on, we're very proud of, is the Care of the Dying Volunteer project. The Royal is part of the Mercury Palliative Care Institute in Liverpool, and our whole kind of ethos in the institute is to kind of improve care of the dying. Over half the population, whether they want to or not, will possibly end up dying in an acute hospital. So part of our goal is to make that experience as good as it possibly can be. And we just felt that, this was possibly a little missing link that we had, and that missing thing was the time really that you could actually sit with somebody. So we feel that we've kind of really, added to the whole kind of compassion and care that we're able to offer people here by just bringing in, really wonderful people to kind of share that journey with them, really.
At the time I was actually working in this hospital, and I saw an advert on one of our internal emails. Some years ago I'd had a relative who died quite young and quite tragically, and it made a big impression on me, and I thought maybe this is something that I could actually do.
We're going into a situation where somebody is dying, and it's not a nice time in many respects, and it's not a nice time for the family, and we're going in there to give them some help if we can.
We can kind of give the nursing staff on the ward that sort of reassurance that there's somebody with the patient, but equally if the patient needs something, we can be out of that room really, really quickly and go and get some help. And the nurses maybe, or whoever the nursing staff, actually realise that they don't, they've got that little bit of freedom to know that there's somebody with their patient who will come and get them if they need it.
We have been told that we are unique in the whole world for volunteers to sit with dying patients. Now obviously they do it in hospices, but in hospitals in this country they don't do it.
The volunteers, when they're in the clinical area, have a really strict rule boundary, because what we didn't want them doing was kind of getting that role mixed up between being a caring member of the clinical staff and being a volunteer, and the whole goal is for them to just physically be in that room as a kind of compassionate, caring connection to humanity, really. If you've got a patient who's dying, you haven't got all the time in the world to sit with them even and just to be with them. So knowing that somebody's actually going to be with that patient is really comforting, I should imagine. And part of the research that we're doing is actually speaking to the nurses after the volunteer's been there to say, well, what was that like for you? Was that an added burden to have somebody else there that you felt responsible for? Or was it a really great help for you to know that actually there was somebody there who would come and get you if you were needed? The early indications are that it's been really widely kind of, raved about, but we need to get the research down now to kind of prove that. I think the fact that we've brought this project into the Royal is, really cutting edge. We don't think anyone else is doing anything as kind of robust as this. It's really fantastic to be able to kind of show what Liverpool is prepared to do for its own community, really.
When patients first come into hospital, they are assessed by the staff either in A&E or AMU. They'll assess the patient's skin, they will check all the bony prominences to make sure that there is no pressure ulcers or wounds developed on there, or if the patient is at risk of developing wounds there. My role is to basically assist staff with pressure ulcers and any advice that they need around wound care. So basically our team, we come in the morning, we discuss any issues that we may have had the day before, and then we get the referrals from the staff in the morning, and we basically just try to prioritise which patients we should see first.
Okay, this lady was admitted on the 7th of January. The lady has medical problems, cerebral palsy, contracture of her limbs, and was malnourished. On the 14th of January, it was noted that she developed a pressure sore behind her left knee. Our action plan would be to ensure the healing of pressure ulcers, to ensure the staff are completely trained, regular pressure area care, and that the care plans are completed appropriately.
Certain patients are more prone to get pressure areas. From what I've seen, everybody in the Royal does do what they can for the patients, and by Paige and tissue viability nurse, you see there's more support for patients, not just nurses or doctors. There's people at a wider perspective that actually know the proper treatment for a pressure area.
It just makes me proud of the job really that our team does and the ward staff do really in trying to prevent pressure ulcers.
Before pre-op assessment, a lot of patients used to have their operations cancelled because they hadn't been properly prepared for their operation. And a couple of nurses started the service, and it's grown from there to a department. So when the patients come in for their pre-op assessment, we check just the basic things like their blood pressure, pulse, their height and weight. We do just a very quick urine test where we dipstick the urine. It's a very useful test for checking up on if anyone's an undiagnosed diabetic, people who've got blood in their urine. Just very basic data, but very useful for planning for their admission. Most of the patients we see, they haven't really got that much experience of hospitals, and it's a really good opportunity to allay their fears and give them all the information they need. But after the operation as well, it gives them the opportunity. Sometimes people think they're coming in and they're going to go home the same day, and they might actually need a longer stay in hospital, so it gives them an opportunity to make sure everything's in place when going home. It's good for planning, it's good for the patients, for all the information that they need. Over the years we've developed the service, we've developed an electronic pathway, if you like, of the questionnaire. But in recent times we found we need to find a way of seeing the patients who are actually quite young and fit and trying to get them through perhaps a bit quicker. So there's a project going on at the moment where we're triaging the patients, and so one of our nurses is actually, she gives the patient a written questionnaire in the waiting room. They fill that in, she'll have a look at that, and if they are young and fit, maybe don't need any tests at all, you know, they go on their way. If there are some issues, for example, if they're on a lot of medications, or be it nurses waiting in the clinic, to actually do the full assessment. And that's something that's just off the ground this week, which we're very proud of, and hopefully that will lead to a better, seamless service for the patients, really. It's very rewarding when you get to the end of, when you've seen someone in pre-op assessment, looked at all the results, got them to see the anaesthetist, passed them fit for their operation, and then they get their date and they come in for their operation. And often pre-op nurses will, you know, go to the ward, you know, see them afterwards, and they're always really delighted to see a face that they knew from sort of maybe a few months ago. All the skills that I've developed over the years on the ward, I'm able to put all of them into practice in my role now. And you know, I really do like that. I've got the opportunity to do that.
Ward 7Y is a haematology ward. We look after patients with different blood disorders, patients with leukemia, lymphoma, patients receiving chemotherapy. We have young adult patients from the age of 17 and patients with other blood disorders as well. Patients on this ward, you need to have a lot of compassion for them because they've been diagnosed, some of them, you know, with a life-threatening illness. And so you need to support them psychologically a lot as well.
Around about May last year, developed non-Hodgkin's lymphoma. You know, there was a time going back in the summer last year. I was in for 7 weeks, so I'm never going to get out of here. I've had some bad days where I've cried my eyes out, to be fair. I've had nurses sit on the edge of the beds, and I've got me through some bad, dark moments. You know, it all comes into the quality of care. Not that it's too much trouble for the patients, you just get on with it.
You sit and talk to them, comfort them, generally speak to them and have a lot of time and patience.
You can never put yourself in their position because you haven't gone through it, but you can just try and, you know, understand as best as you can. Sometimes if we feel that the right decision is not being made for our patients, we have to have the courage to stand up and speak out for what we feel is right. We get excellent feedback on this ward because of the type of patient that, you know, that we nurse. It is very rewarding.
I love it.